In which case, what I would do would be to bring this around, take hold of the leg like that, still the apex, and push down on the apex, having held the leg up. But I'm smart. I don't really want to sort of be holding the leg up in the air. Now, I'm not so smart that I set this up to start with, because what would have been a good idea would have been to have had Chris's head. I did think about this, but it would have been difficult for, we'd have had to turn the whole table around. But if I'd had him in such a way that I could just simply lift this up, that would lift the leg up in this position and put some anterior rotation on here through the iliofemoral ligaments and through the rectus and things like this. And then I could have taken the slack up, brought this joint down, and then I could have got over him and done some little impulses in this way. So all of this, starting from our two basic points of push the ilium forward and the apex of the sacrum also vertically downwards, produces that rotation effect like this. We can flatten the back, we can then come into the leg, we can lift the leg like this, and sometimes you're in a good position to modify the muscle energy procedures of pull downwards with your leg, and he pulls down and I still fix the apex of the sacrum here, and so we can keep converting between mobilizing, little impulses, muscle. And that's how we should be doing it, isn't it? There isn't these single answers. We kind of use what we've learned and we put it in together to our synthesis. So here's the technique that I think is quite useful as far as reducing a posterior rotated innominate or a posterior rotated ilium into anterior rotation. Just try that one. This is not anything new to you. But this is it, over the thing, and just a little impulse, okay? Try building it up as I did, just on the... With the anterior rotated ilium, then we're obviously going to be using techniques where we bring in flexion of the hip. I can engage the anterior superior iliac spine. I can engage the ischial tuberosity there like that, and I can push down in such a fashion. To make this more local, if I have a very flat sandbag, I can place the sandbag under the sacrum, so that this is under the sacral base, so that when I take the pelvis back in that fashion like that, the sacrum just doesn't rock on the lumbosacral angle. I mean, there's no point in kind of working away and pushing if we've got a stiff joint, just transmitting its stiffness to a joint higher. So this localization is very important, and it's one of the problems that I have with some of the muscle energy techniques that have, we've just had to change because it's so unsatisfactory to us when they don't use very much locking. Everything's kind of moving and it's little tiny pushes, and you ask yourself, why would that move this stiff joint? Why wouldn't it just take up all the linkages unless we put the linkages in a supported position? So we really try and do that. Olaf has got a technique which I sometimes use. I tend to use this one, or in side lying. Can you lay on your side here, Dan? Of coming up like this with my pillar, as I mentioned, that goes into the center of the table that I use for hips. I can put the leg back, I can put the pillar down there which holds the leg, and I can come into a position now and really push on the ilium like this. Or I can push on the ilium and also try and hold the base of the sacrum. So I try and localize these as best I can, but these two, as you see, are exactly the same technique. It's just one's in side lying, one's in supine lying. The one...
With the sideline one, would it be more effective to lock up the lumbar spine?
You could do that in extension or flexion, yeah. Stoddard certainly does that. Now, thinking, we're going to have great thinkers here. That's very good. Come on over towards me, please.
Why do you do it from the opposite side of the patient, the supine technique? Why not from the same side?
Oh, I'm going to show it from the same side. I find that from the opposite side, you kind of lean in and you get your body over. And, it's like this business of this and my thumb. I don't want my back to go. So this leaning on patients is really part of our technique, but it also saves us. Whereas if I'm on this side, I really can't lean on anything. And I get used to leaning on patients. They become part of me. So I kind of like to take my body weight on the patient. So that's why I do it. The one on this side, though, let's say I'm now going to produce a one on this thing here, is to come over to the side. I can fix the sacrum with the edge of the bed now. Come into there and then push down like that. Pulling up with the ischium, pushing down on the ilium like that, getting a little bit of motion with the flexion of the hip. He's right over on the sacrum. It's right and supported on the edge of the table. I make sure that my body is stopping him kind of rolling here, so I threaten the spine, and then I can do a series of little movements like that. So that would be how I would do it on the near side. This is Sweat City, of course, when you're doing all this kind of stuff. So let's just do those two techniques so that we just roll this up. It's only going to take you a couple of minutes, and then I'll show you the Chicago technique, which is a much bigger technique to do and quite satisfactory if you've got somebody that, you know, it fits for. Then we've got another couple here, and then we can sort of... Why it's called the Chicago technique is that it was developed at the Chicago School of Osteopathy in the early 20s. And variations of this technique you see quite a lot all over the time. Now, it's got about 3 or 4 stages, and at any stage, if the patient's having a problem, you just ease off and don't continue on. We're going to be using a congruent lock, actually, if you work it out. I've tried using non-congruent, and it just makes the technique too complicated. And all we try and do is to create a side bend towards me of the whole spine. That's the first thing, like a C-shaped curve. In other words, I pull the patient's waist towards me and then take the legs like this and the head like that. And you just have to tell the patient that any discomfort, let you know. And it's, funnily enough, it's not a particularly uncomfortable procedure. This guy's a bit more mobile than I thought there. Okay, so what I want to do is this. I'm going to ask Ellie to just put her hands behind her neck, interlock the fingers like that. I put this C-shaped curve on her, and I'm going to rotate the spine towards me. And what I'm going to tell her to do is just to let the pelvis come up, not to try and shift her body about to take the strain off, because this is part of what the technique is. And I'm going to place my hand on the anterior superior iliac spine. So let's see how we go with this part of it. So I'm just going to take her around here, rotate her and move her back into extension there. So at least with a congruent lock, we've got extension. Then she has to hang on there and not let go. And I just thread my arm downwards like this, and just place it on the table. So I'm just holding this. Then I'm just going to take up the slack here. Now I shouldn't have her right up in the air. I've moved this down, I've put a little bit of strain on her like this so that she's just very, very close to the table. So that when I give my impulse like that, it's not going to be very far to go. So this is most important, that you don't have her in this position and you're pushing down here. You've got to be going very close to the table. So that's important with this technique. So here we go. She comes around. I carry her back. I thread through. I ask her, is that okay at this stage? Now let me just build up a little more tension into there. And now I'm going to just say, breathe gently out. And that's the movement there. Okay, just a little movement through. I cheated a little because I knew I couldn't click Chris there. Okay, but this is, obviously you'd have to make sure you hadn't instability in the spine or anything like this, but for an anterior rotation, this technique is not as stressful as it looks, is it? But it's not a matter of spending ages doing it. It's turn this way, turn, hold, move back. How's that feel? Do it. All right, let's just do that one. Just a downward movement. Things, and you're all doing well. The last of the techniques that I find to be useful is the technique for the reduction of a superior iliac subluxation, the so-called upslip. Kaltenborn showed me this technique a long time ago, and it was kind of like a shotgun technique. If you couldn't think what to do and you were still having problems, you did this, and then it seemed to fit perfectly with what the ileal subluxation was. And within the Norwegian system, when you are testing movement, you test for anterior and posterior rotation, the ability to do it, and also upslip and downslip. And does it cause pain? Is it correctable? And so they would come onto the base. This is for the anterior posterior movement. They would be on the base of the sacrum and pulling this like this to see whether it will come into posterior rotation. They would go onto the apex of the sacrum and push downwards like this to see whether it would go into anterior rotation. They would come up on the side of the right side of the sacrum here and onto the iliac crest and push down like this, which would be the correction of an upslip. Or they would take a contact on the base of the sacrum like that, on the ischial tuberosity, and push up like this, so that some of these things that were never described in terms of upslips and downslips in their method were actually in there. It's just that they didn't have sort of like such a name for them as the muscle energy people did. But they were there and they were tested for. Now, one of the things that is quite useful is the correction of the superior ilial subluxation. I think both of these exist, both the upslip and the downslip. The upslip, when people miss a step and bash down onto their foot or land too heavily on one side. The downslip, when people are running along and catch the leg and lurch forward, and it gives a sharp tug downwards. And perhaps in bungee jumping you might get bilateral downslip. I don't know why anybody would want to do that. Okay, so I'm going to get the patient here to move down towards me, and I'm going to use a technique where I give a little tug on the leg and I try and stabilize through the sacrum on the ipsilateral side. Now I'm going to come over the patient's leg like this so that the tug will be applied through my legs like that. All right? And I obviously need a table that goes up. I don't want the leg to be too far off the end in case I slip and I land on his tibia. All right? And I've never had that problem. Make sure that his head isn't in a space of the table like those that come down. So that you do that. So all of these things you have to kind of think about. And I will support the leg in case he's got a little laxity in his knee. Now I could check that all out before I started. And I'm going to try and put the hip in a medial rotated, slightly adducted position so I get a little less movement in the hip joint. So I'm going to move down here, put a grip on the anterior aspect of the thigh, pick up the motion on the lower part of the sacrum on the same side like this, take up the slack, and it'll be just a matter of a little pull down like that. Just pull down. This I find to be very effective. Cliff Fowler has done some work on, as you've probably seen, of looking at an upslip, and he recognized this in posterior and anterior rotation, and he feels you should correct them in whatever rotation they've occurred in, and then correct the rotation if it's necessary. So, for example, if it was in anterior rotation, he just does a little tug like that. But I really don't like it, I must say. It's so much against, for me, not having stabilization that I find some of these techniques extremely difficult to do if I've not all stabilized and I can feel where I am. So he's done a number of techniques like that, but I still prefer the neutral one of coming down in there and that little tug there. Now, you need a table that goes up and down, of course, and occasionally you get so a patient's longer than you are and you can't reach this. So you can always go and get an assistant who can put their hand like this, okay, and you can get into a position like that and do your little tug downwards while the assistant holds up. So it is possible to do this as a paired technique in the event that you can't actually effect it all yourself. So let's just try that, and then we'll kind of stop techniques, because there's no point in just kind of doing more and more, just because these have been the useful ones for the sacroiliac, as well as all the mobilization that you know. Okay, so let's just try the upslip, and then we'll... Closing. Just remind you once again of the starting point, which was where are all the problems in terms of contraindications, and most of them are related to the vertebral artery. I've given you an article in there by Bogduck which is extremely good on the vertebral artery, but it may be sort of salutary to look at Domisa's comment here that the spinal cord and the brain are the most highly developed structures totally dependent on a superabundant blood supply. A thorough knowledge of the anatomy of the cord circulation is essential knowledge before embarking on the management of spinal complaints. Without this knowledge, the would-be healer is embarking on uncharted seas. So it's a very important thing that we kind of just make sure we understand this. In terms of the definition of vertigo and dizziness, which is one of the manifestations of vertebrobasilar insufficiency, is that dizziness and vertigo can be used synonymously to describe spinning, swaying, ataxia, and other similarly described sensations. It's the consciousness of disordered orientation of the body in space. And there are quite a lot of causes of this, but the one that we have to be so cautious about when we're dealing with the craniovertebral area is the development of vertebrobasilar insufficiency. And as we saw the other day, and this is an article, or this little diagram here is in your notes in the Bogduck article, that there are a whole variety of things from the eyes, the labyrinth, the neck, and so on, but it's this vascular one that we have to be so careful about. And in terms of vertebrobasilar insufficiency, those 5 Ds of dizziness, drop attacks, diplopia, dysarthria, and dysphagia are really, really important. And if coupled with this we have nausea and things like this, we should never cavalierly ignore those signs, particularly, obviously, things like drop attacks and dizziness, but the difficulty of making speech or the numbness around the mouth, all that kind of stuff are important. And just remember that the vertebral artery is very much dependent for the total supply of the cervical cord and also of the posterior cranial fossa via the radicular arteries, which are going in here at every level and join with the anterior and posterior spinal arteries, and also in this area here by the development of the anterior spinal and the 2 posterior spinal coming down, joined with these radicular arteries, and that's what supplies this area of the cord. But the posterior cranial fossa is supplied by the vertebral arteries as they come up here, forming the basilar artery, and these are the pontine branches here. Now, this does join in with the circle of Willis, and if movement or if blockage in this area was sufficiently slow, presumably the major supply through the middle cerebral arteries and the carotid arteries and so on would be sufficient to make this up. But if we suddenly lose activity here, it almost seems that for a time this acts like an end arterial system. We don't get a perfusion back through quick enough. So we're into major problems. Now, in your notes, I've given you an article of cerebrovascular accidents, and you should read this. It's got some of these things of the locked-in syndrome, the person that all they can do is they're totally conscious, they can't hear, all they can do is move their eyes around like this, because of where the damage took place. The article by Klenians and Terrett in your notes describes all that in great detail, and I don't think we need to go over it. I just wish to just reiterate 1 or 2 points. So, if we look at the vertebral arteries supplying the posterior cranial fossa, and also the vertebral artery down here supplying the cord through the anterior spinal and the 2 posterior spinals, sometimes which come off these posterior inferior cerebellar arteries, then the spinal cord also is dependent entirely upon the vertebral artery. It's a very important artery. when we get into the spine itself and we look here, we can see the importance of this thing, because the anterior spinal artery supplies most of the high metabolizing structures here, the gray matter of the cord. And so things that happen to the anterior spinal artery, such as osteophytic bars, can affect this and then affect a section of the cord. And there is some sort of evidence to suggest some of these long tract signs that we're seeing perhaps are blockages of the anterior spinal artery. But this is like an end arterial system again, and if we start switching off this blood quickly, nothing can make it up. So we've really got to have a good handle on looking at vertebral artery insufficiency, and I think you have done that in each of the courses because we've been very careful about it. Remember where 90% of the damage occurs. There are 4 parts to the vertebral artery. There's the first part, which comes through the cervical fascia before it gets into the transverse process of C7. Then we've got the second part as it goes up through the transverse foramen. We've got the third part as it winds around here, and the fourth part as it goes in through the posterior atlanto-occipital membranes, okay? And this is the one that we have to be so careful with. As we turn to one side here, it flattens out that artery. From the other side, it puts a major kink in the vessel there. And this other artery has to support the circulation while we have that kink in it. If this area is hypermobile, as we have here, we know that that forward movement will be even greater. And if it's even greater, it causes major problems. So we know that when we're testing, we have to see the anterior movement forward, and that if we've got a posterior movement which will not come back, we can presuppose that that forward movement is hypermobile, and we must not manipulate forward. So we know that, we saw the techniques into rotation, and we really emphasize the business of distractive mobilization. So just remember the first part and or the third part, and remember the second part, which is as it goes up through the intervertebral foramen here, we can have osteophytes which tend to move back onto the artery as we see here, or osteophytes round the body of the vertebra, which can also cause this obliteration. So much more important at C1-2, but still we cannot ignore complications of osteophytosis lower down in the spine. So remember the vertebral artery. Everything about this course, in terms of safety, we have to focus very much on vertebral artery problems. And I'd like you to sort of really remember that. Now then, just in sort of conclusion, I'd like to just sort of perhaps, as a sort of note of caution, because I think you've managed so well this week, you've looked at safety, you've developed good technique, but damage is caused by ignorance of the condition being treated. These are Lewitt's words. Ignorance of the indications for manipulation, ignorance of the techniques of manipulation, and the use of undue force. So when we look at this, it's obvious that we need to have our medical conditions sorted out. We need to know our biomechanical sort of principles. We need to check up on the very best techniques that can be done, and then to make sure that the force is rapid, it's quick, but it's over a very, very small amplitude and in a safe direction. And on the whole, the safe direction is towards distraction. Now, let me just finish by just going over this. Here's a word of Monell. Nice to go back. And this is the father of John McConnell Monell, J.B. Monell, who worked for a long time as Cyriax's predecessor at the St. Thomas's Hospital. That movement begets movement and function begets function, always providing that neither irritates. It is always wise to do less than we think might safely be done, and to gain a small and real improvement, than to take the risk of doing too much, thereby gaining nothing or rendering the condition worse than before. That sounds a little bit like Paul Brand, doesn't it? You know, that sort of words. What have we got going against us? Some of these comments, such as Wardwell, who got a PhD writing a sociology of chiropractic, so is obviously somewhat biased, I think, that physical therapists are the physician's traditional assistants in physical medicine. For these to take up manipulation would be as inefficient for a physician to prescribe manipulation to be carried out by a technician as it would be for a surgeon to stand by while an assistant performs his surgery. This fails to understand anything about us as a profession. But his words keep coming up, and as I say, he got his PhD for looking at the sociology of chiropractic. He's just written a book on the history of chiropractic. To put him down as an unbiased figure would obviously be foolish. Let's have a look at somebody else who we perhaps would agree with a little bit more. This is Vert Mooney. We believe that there is a role for passive-assisted joint mobilization, manipulation by the therapist. There is every reason to expect that a joint unable to proceed through its full anatomical range is abnormal. If mobilization by manual therapy can increase this range, the joint should benefit. If this is the only therapeutic maneuver, it is a short-sighted one, but when incorporated in a progressive exercise program, focused on improving function and enhancing strength and endurance, it has a useful role. Physical therapists functioning in a responsible medical environment offer the greatest potential for the maneuver to be pursued in an ethical setting where in comparison of results with other methods can be challenged. So there are protagonists and there are antagonists to this thing, and I think that we should, really sort of strike a battle. And I think we've got to sort of face this where it stands. We've got to be confident of what we do, and I think that we're in a position to sort of do some things. One weekend, or one day with my workaholism rife, I decided I would go to lunch, which I often don't do. But of course, going to lunch and taking the chance, I sort of felt that I really should take a book with me and do some reading of technical stuff. If I was going to take time off, it had not better be wasted time. And I picked up from my bookshelf a book I'd been meaning to read for a long time, but being as I don't treat many hands, I'd sort of failed to read. And this is Paul Brand's book on biomechanics of the hand. And I sat down in this restaurant and I started to read a chapter on post-operative stiffness and adhesions, and it actually emotionally moved me. And I thought to myself, this should actually be a creed of behavior, and I mean to get this magnified, and I mean to put it on a board, and I mean to sort of go and look at it, and I mean to sort of say to myself in the morning, like a little shrine, this is how I would like to spend my day, doing this kind of thing and having this attitude. And I'm just going to read a little bit to you. To restore the balance and beauty and power to a disabled hand is an adventure. The stakes are high, the rewards are exciting, the penalties of failure are grievous. Even today, we are sometimes haunted by the spectre of hands long past that had a small disability before we worked on them and had a large disability after. In most such cases, it was not that we made mistakes in the plan of reconstruction. It was just that while we were doing some good things, we allowed the overwhelming bad things to happen. The hand became stiff. Adhesions developed, tendons became adherent, and the hand became swollen and painful. And somewhere